Once again, if you do not want to be part of the recording, please turn off your video. We're very lucky to have this group speak to us today and to have Veronica Vieira moderating this session. She is a professor in the program of public health and a member of the Child Family Comprehensive Cancer Center at the University of California, Irvine. Her research focuses on epidemiological analyses of health data for examining the contributions of known risk factors and environmental risk factors to the underlying pattern of disease risk, with a particular emphasis on location, on the importance of location. She has extensively worked with reconstructing historical environmental exposures using GIS and has extensive knowledge of groundwater modeling, air pollution modeling, spatial statistics, and persistent environmental contaminants. With all of this, she is also a former CBCRP council member, and thank you for continuing your excellent work with CBCRP by moderating the session for us today. I'm going to hand the session over to you.
Thanks, Katie. I appreciate the introduction. Can everybody hear me okay? Okay, great. So I am very pleased to be the moderator today and to introduce to you two of the exceptional panelists that we have today. So our first panelist is Barbara Cohn. Dr. Cohn is the director of the Child Health and Development Studies, or CHDS, at the Public Health Institute. CHDS is home to a groundbreaking study which originated in 1959, designed to shed light on the various factors impacting health during pregnancy and early childhood. Between 1959 and 1967, 15,000 pregnant women and their families were enrolled. Researchers continue to study these rich data today and conduct important follow-up studies to further examine how events during pregnancy impact the subsequent health of fathers, mothers, their children, and grandchildren. With support from the California Breast Cancer Research Program, Dr. Cohn has implemented a multi-generational participant advisory council for community-based participatory research in the cohort, and has been collaborating with Julia Brody and Silent Spring Institute on the consequences of returning information of biomonitoring results to study participants. In addition, Dr. Cohn directs research on whether early life exposure to environmental chemicals during pregnancy affects obesity, immune function, reproductive health, cardiovascular disease, diabetes, neurodevelopment, cancer, and health disparities in mothers and their children and grandchildren across the lifespan. Welcome, Dr. Cohn, and thank you for being here. Our second panelist I'd like to introduce is Rachel Morello-Frosch. Dr. Morello-Frosch is an environmental health scientist, epidemiologist, and professor at UC Berkeley School of Public Health and Department of Environmental Science, Policy and Management. Through the auspices of the Sustainability and Health Equity, or SHE-Lab, her research focuses on structural determinants of environmental health among diverse communities with a focus on social inequity, racism, psychosocial stress, and how these factors interact with environmental hazard exposures to produce health inequities. She also collaborates with environmental justice partners and regulatory agencies to develop science policy tools that improve decision-making and advance environmental justice and community health. Dr. Morello-Frosch is a member of the National Academy of Medicine and serves on the Biden administration's White House Environmental Justice Advisory Council. In this session, Dr. Morello-Frosch will start us off with a presentation on the opportunities and challenges of biomonitoring and results return and exposure in health studies. After the presentation, we will open the session up to a discussion by the panelists, Dr. Cohn, Morello-Frosch, and questions from the audience. Please ask any questions to the Q&A feature at the bottom of your Zoom screen. And Rachel, I take it over to you.
Thanks, Veronica. Can people hear me okay? All right, great. Let me see if I can share without issues here. Okay. Do you guys see a presentation with no notes?
Looks good.
Awesome. Excellent. Okay, so I was asked to kind of kick us off and talk about approaches and opportunities and a little bit about challenges, although I think the challenges issue, I think is good to delve into in the discussion around biomonitoring results return in exposure and health studies. So I'm going to be highlighting work that has been funded by CBCRP, our Women Worker Biomonitoring Collaborative, specifically our work with biomonitoring women firefighters and office workers in San Francisco. And then talking a little bit about another project that we have launched, and both of these are in collaboration also with Silent Spring Institute. But the second project is with a pregnancy cohort. So, and I think this will help sort of germinate some ideas and questions for discussion about opportunities and pitfalls. So just to kind of set the table, if you will, the National Academy of Sciences has spoken out on this issue of results return in general, which also includes biomonitoring results return. And here's a quote from the report that was pretty unequivocal about the benefits of results return for participants, both in terms of sort of a reciprocal understanding that when we invite participants to engage in a study and participate, that we are undertaking a relationship. And returning results is a form of respect, ensuring transparency in the scientific enterprise, cultivating trust, and that there are significant benefits to participants as well as investigators in terms of results return and report back, including in biomonitoring studies. And I've been really fortunate in being able to collaborate with Silent Spring Institute now for over 20 years, where we have really sort of dug deep into thinking about how do we do results return and how do we understand a motivation for doing it. More recently, results return in biomonitoring studies is a very good way to engage study participants that can improve their long-term retention and engagement with your study, particularly if you're doing a cohort study. And it can strengthen a lot of areas of research ethics in terms of, again, that transparency, the respect, the beneficence, and all those other kinds of things that we learn about when we're dealing with IRB boards and protocols when we're getting our studies evaluated and approved. Together we have interviewed a lot of study participants in a variety of studies, both ours and other people's studies, including exposure studies, but also epidemiological studies, to really understand what motivates participants to want to get their results. How do they think about the underlying scientific uncertainties that we can't, the information that we can't give them that they might otherwise want. So for example, if we tell them that we have found chemicals in their urine or their blood, often the question is, to what extent is that related to any health issues I might be facing? And so how do we understand the desire to receive their results, and also how do they understand and react to scientific uncertainties and the clinical significance of what we find? And I would argue, back in the day when we were first developing protocols to report biomonitoring results to study participants 20 years ago, IRBs were not too psyched about the idea. I feel like there's now mounting consensus among researchers and many, many, many IRBs about the benefits of sharing this knowledge, including improving public and environmental health literacy among study participants. I think the key take-home message is, scientific discovery is very arduous and slow, very iterative, and the participants that are in our studies and the communities that we study, they want information now. We argue that supporting results return can advance what we call the 3 Rs. It can enhance the rigor of our science by improving participant engagement and retention in our studies, enhance the relevance of the questions that we're pursuing to promote environmental and public health literacy, and the reach in terms of really providing a great pathway to translate scientific results into action, and empowering the communities that we work with and study to do so, whether that's highlighting opportunities to reduce exposures in terms of individual and collective action, but also promoting engagement with clinicians and health providers to better understand environmental determinants of health. We were fortunate in that CBCRP took a leap of faith to support our biomonitoring project that we undertook in collaboration with the San Francisco United Fire Service Women, which is part a conglomeration of women firefighters within the San Francisco Fire Department. Also, the San Francisco Firefighter Cancer Prevention Foundation gave us additional money, particularly to support some research translation. And what happened was the women firefighters in San Francisco fought many decades to gain entry into this very lucrative and prestigious job through a series of lawsuits, which actually I worked for the civil rights organization that was participating in those lawsuits decades ago. And now women have gained a significant entry into the fire service. San Francisco has the highest proportion of women in the fire or any urban fire department in the country. But they were concerned about what they perceived to be elevated breast cancer rates in their rank, particularly premenopausal breast cancer. And initially they wanted to see whether or not exposures in their job might be related to elevated risk of breast cancer. And so that launched a conversation, and we can talk about this during the panel. But ultimately, instead of doing a health study, we decided to do an exposure study to focus on chemicals that we know already were of concern based on toxicological evidence for breast cancer. We had firefighters as well as female office workers who provided sort of the control group. And as part of that process, our partners in the fire service on this study, which made it clear that, you know, in order to get firefighters to participate, they were going to want to know what we found. And so it became clear that we were going to be developing a report back protocol. And you know, again, in collaboration with my colleagues at Silent Spring Institute, and we've written a lot about this based on our prior work and other studies. These are the basic questions that participants want to know when you're reporting back. You know, what did you find? How much? Was it high? Is it safe? Where is it coming from? And what should I do? These questions sort of help set the framework for how we might approach results return in our biomonitoring studies. So in terms of how we do this, this is sort of a broad schematic of how we have done this in the Women Worker Biomonitoring Collaborative, but also how people have done it in other studies. So, you know, we co-develop these protocols with the input of study participants, often starting with things like focus groups and interviews to get a sense of what are their expectations, what kind of information they want to learn. And then we often will develop a prototype based on the answers to those questions. And then we basically undertake pilot testing or reusability testing, have people try these prototypes. We explain to them, you know, pretend this is your data, go through these materials. It can be in print, it can be electronic, and more recently, it can be on your smartphone. And we get a lot of information based on how well, you know, the elements of the report back protocol are working. And based on that feedback that we're getting from users, we do a lot of iteration, adaptation, and revisions. We finalize, and then we deploy people's actual results. And then we do a lot of evaluation in the back end. We spend a lot of time interviewing participants, and more recently, you know, we're starting to collect analytics on where people are spending their time if we're using electronic report back. And then that helps us learn lessons in terms of adapting the protocol for the next round or another study. So this is very much of a collaborative process with participants in studies, regardless of whether you have a sort of community-based participatory model or a more standard, maybe less a community-based participatory model. You really want to and need to engage your study participants in this process for developing your protocols. So Silent Spring has developed what they call a digital exposure report back interface, otherwise known as Derby. It is a very nice software platform that is very nimble and adaptable for a variety of interfaces, audiences, things that we're monitoring for, et cetera. It is becoming more widely used for other studies in addition to the ones that we have undertaken together. Its adaptability enables you to sort of get the input from your specific study participants, and you can engineer those changes quite easily. So here's an example of sort of what the report looked like for the women worker, for the firefighters, and again, based on a lot of their initial input. This is their landing page, and they wanted a computer interface, so this is all digital. They have the option to be able to print these things out if they want. And then they get a lot of information on specific messages about their own results, sort of highlight messages. So what's your personal headline? Which chemicals that we measured were higher than everybody else, for example? Where does this stuff come from? What do we know in general about their health effects? What does the science say? And then what are some strategies that you can use to reduce your exposures? And again, remember that we're talking to both our office worker participants and our firefighter participants. So you see things that everyone can do, and then some things that are specific to firefighters. And then you can actually see your individual level results. This is for PFAS. These are graphs. And again, we developed these graphs with a lot of input and testing with our participants. So the blue circles are all the study participants. The orange circle is the one that this is the particular participants' results. The flag shows the median for NHANES results, so a representative sample of the U.S. population. So they can see kind of where they land compared to other people in the study, as well as compared to general U.S. population, if that data are available. And again, it allows you to sort of visualize where you are in relationship to other people. Many of these studies do not have, many of these chemicals don't have safety benchmarks, which again, I think is a challenge in biomonitoring and results communication, which we should talk about. Okay, and we show the outliers and other kinds of information in these graphs. More recently, Silent Spring has been collaborating with us at UCSF for a study that we've been, a pregnancy cohort study that we've had there for quite some time, where we have been recruiting a diverse cohort of pregnant women to look at combination of diverse chemical exposures. We were looking at here developing a smartphone interface for results report back for our pregnant participants. So these are screenshots again of what people see on their smartphones. These on the far right is again the summary of sort of high level messages of what we found in a particular participant. So showing them where they had significantly higher levels compared to everybody else. And then an explanation of what the different chemicals are and where they come from. And then again, here are the graphs, very similar to the ones that I was showing you for the firefighters, but making it adaptable to a smartphone interface. And so the last thing I want to leave you with is, I think one of the challenges of results return in biomonitoring studies is, what do we tell participants about what they can do? And in public health, we have a strong desire to tell people and empower people to tell them what they can do to protect themselves, to reduce exposures, which is a really important motivation. And yet we know, as people have been talking about in the plenary session, the ability to actually reduce exposures is much more challenging than one might think. So what we've often done is, really trying to make clear in our results return where the sources are, make clear when there's multiple sources, and then also make clear where action should be divided into things like individual level action that people can take. So on the far right, things that might come from consumer products that might be easier to avoid either by not using certain products, and for example, indoor use of pesticides, that can be very straightforward and be very effective in reducing exposures if you just stop using the product altogether. But then also being really clear that there's certain kinds of products, either consumer products or drinking water contamination or outdoor sources of contaminants, that as an individual, we aren't that able to control at the individual level. And it's really more about collective action and policy change. And so in our results return, we've really tried to make those distinctions so that people don't necessarily feel the sole responsibility and burden of exposure reduction, when we know for that individual level action might in fact be limited for certain types of chemicals depending on their sources. So here's an example with Derby and this iPhone interface that we have for our chemicals in our body's pregnancy cohort. Here is an example of sort of individual level action around flame retardants like PBDEs. So washing hands often, keeping dust levels low, but then also just being really clear about what have been some policy changes that have really been significant for exposure reduction, and other ways that people can engage more in policy change and what's going on. And the last thing I want to say is that report back really can catalyze action on the part of participants. So for our firefighters, it really provided them the data and the leverage they needed to start having conversations with their colleagues and their superiors about changing cleanup practices, decontamination practices at work and home to reduce exposures. So again, elucidating opportunities and giving them the data that they need to sort of make the case for those more collective action opportunities. And then for our office workers, they use their results to really start lobbying the city, for example, to do some different kinds of sourcing for flame retardant free furniture in office settings. So just to wrap up, participant and or community engagement in results return in biomonitoring studies and developing those tools, whether you're printing them out on paper or doing something great on a smartphone or something in between, I think really transforms our science and its impact, because it centers community and participant knowledge. It, I think, democratizes the scientific process, which helps develop trust and understanding that sometimes that knowledge and what we do with it is co-produced and has to be collaborative in order to have impact. And it does that through enhancement of environmental health literacy and helping facilitate sort of research translation from scientific results to regulatory change. And, our participants are often the most powerful in helping us, make those changes. And ultimately, I think the goal of results return, as I think stated as somewhat in that National Academy of Sciences report, is, it's not just enough to tell us, what we found and where it comes from and what we as individuals have to do about it. But what we really want to do is, move from translational research to transformational research, which really requires engaging our participants in that level of conversation about whether and how to do report back in biomonitoring studies. And in terms of food for thought for discussion, I think we want to, some of the challenges is, how do we understand participants' diverse perspectives and motivations for participating in research and their expectations for us returning results? How does it affect their engagement with the study and their emotional and action-related responses? And the importance of just, knowing that, we develop protocols and we're always going to be in the beta version. We're always going to be fine tuning it, improving it, and evolving it depending on what communities we're studying and who our participants are. And I think one of the biggest challenges is ensuring that we have adequate resources to actually do this well, which can often be a challenge because many granting agencies don't necessarily fund that element of the science, and so it can be under-resourced. And thank you. Look forward to our conversation.
Thanks, Rachel. So for those in the audience, if you have any questions, feel free to raise your hand and unmute yourself and go ahead and ask. You can also type them into the chat and I can read them for you. And we'll start with Lori. Please go ahead.
Hi, thank you. I love that results return reporting back. I'm a patient advocate, and I'm just curious if somebody's looking at their results and they're, pretty negative, or they're one of those negative outliers, they may be super concerned. And is there then a process where they can actually talk to somebody instead of just interacting with the computer and move forward?
Yeah. And Barbara should jump in too, because yeah. So I guess two things just to highlight. One is when we enroll participants, we set expectations. And one of the big things that we do is we say, if we take a blood sample or a urine sample from you and look for chemicals, we're going to find something. It's inevitable because we're all exposed to chemicals all the time from a variety of things. So really setting expectations that we will be returning something to you, and we will find something. And the second thing is, yes, we return the results. The interface makes really clear who to contact to talk about your results. In our community engaged participatory studies, we also have meetings with and invite participants who want to come and sort of give a presentation of the aggregate results, and then provide some time for individual participants to talk to the research team about their individual level results and any questions they may have about it.
Thanks, Rachel. Barbara, do you want to add something?
We did the same thing. Our project also used Derby. We owe Silent Spring a huge amount of gratitude for the work that they did to develop Derby. I didn't know Derby is available on mobile phone. We have a current project that we'd love to use. I have to talk to Julie. She didn't tell me that, but anyway. And I just want to echo every single thing that Rachel said. We also saw in our study, we had about 600 women in our second generation, the offspring of the pregnancies that were in the CHDS, whose chemicals were measured. And CBCRP also funded our research. And we actually returned both aggregate and individual level data. And we had a crossover to design to see whether it made any difference to get your individual results versus getting only the group's results. And the answer is that it did matter. And that the thing that was most exciting is, well, these are California women, and they're also heavy participants in the sense that they've been involved in CHDS before. These were women who had been contacted multiple times and knew what we were studying. They had really strong individual level information about knowledge about, what these chemicals were and why they might be bad. But they really didn't know that the government doesn't regulate them all, doesn't measure them. And the thing that was really most exciting that we published fairly recently is that adding that information changes their entire approach to advocacy and what they can do next. They were outraged, they couldn't believe it, because there's this idea that the doctor knows and that the government knows and that somehow all this is being taken care of. So there are all kinds of levels of knowledge, and having your own individual results, it indeed changed at least their reported intention to engage in both advocacy, political work, change, social change. And that was very exciting. And that was true for both Black and for white participants. We have a very strong representation of Black women in our cohort. Was originally 22% Black in the old days in Kaiser. And so it's very significant. We don't have as many Hispanic and Asian populations as currently live in California, because in 1960 they weren't here or weren't in Kaiser or both. But everything that Rachel said is what we found, and Derby really is great. All of those screens look exactly like what we've seen before. And I just, Julie and her team are amazing. And we were scared. I had people on my staff, researchers on my staff, who said, we can't tell these people this stuff. They're going to panic. They're going to freak out. We had a couple of calls that required some discussion and some assurance. It's not scary to find out what's in your body. And I would imagine that pregnant women, I don't know, Rachel, you could talk about this, might be more panicked, but people are reasonable. They get their medical results all the time. Their cholesterol is high, or their blood pressure is high, or their father died of cancer, whatever it is. And people seem to manage those things, and it seems unfair for them not to have this knowledge. So anyway, Rachel, what about the women who were pregnant at the time? Our women were midlife when we did this work, but.
Yeah, great question. I just chatted everyone a PDF of the paper that Barbara was just referring to about her study in Derby, for those of you who are interested in reading more about it. Yeah, so again, what happens is we test the women while they're pregnant, and then by the time they get the results, they've had their babies. So for them, it's more like it makes them think about the ubiquity of sources of chemicals in their lives, because pregnancy is an interesting time. People become a lot more self-aware. A lot of pregnant people stop drinking alcohol, stop drinking coffee. They maybe avoid certain activities because they want to avoid certain kinds of exposures. And so I think nobody freaked out, but I think, I think, as Barbara said, people learn a lot about the ubiquity of chemicals in their lives, and the fact that they're exposed to a lot of things that are not adequately regulated by policy. And that's a huge sort of discovery, if you will. And I think then some people are also disappointed to learn that despite their efforts to, eat organic or read labels, that they're still being exposed to things that they're trying to avoid, like parabens or phenols and things like that. And so that again sort of opens and I think pregnant people are under a lot of pressure to sort of be good while they're pregnant. And so part of that conversation is to alleviate them from that burden and help them understand that this is not about them and whether or not they've done enough. This is about problems in our regulatory framework and how we regulate chemicals in everyday products.
Thanks for that, Barbara and Rachel. Any other questions? Susan, welcome. Please go ahead.
Hi. So I just was hoping to steer the discussion back to a point that Rachel mentioned, which was, how do you communicate results when there aren't health guidance values? Because that's something we've struggled with. And sort of related to that is, for the first time, our program has collected some information, has done some biomonitoring on biomarkers, using biomarkers of effect. And that has been very challenging to try to figure out how to message those results. So I'm just curious if anyone has any thoughts or ideas on that.
Yeah. So one of the things that we do, again, when we're enrolling people very often the chemicals that we're measuring, the reason why we're studying them is because they're understudied and there aren't benchmarks.
Right.
So we make that super clear, like we're not going to be able to, when we return your results, we're not going to be able to compare it to any kind of regulatory standards because there aren't any, because these chemicals are woefully understudied.
So
And the
do you
reason-
actually, I'm sorry to interrupt, but do you actually make that clear before, like at the onset of the study, like in the consent form and that kind of thing? Or how do you, how and when do you communicate that?
So oftentimes when we're pitching the study, or if we're co-developing it with our community collaborator, if it's a community based participatory research study where the participant community is like a co-PI on the study, we have a lot of good discussion because oftentimes community partners are the ones that are pitching the study to see if there's people who want to volunteer.
Mhm.
So those are the kinds of things that we try and make clear. We also make clear if it's just an exposure study, that it's just an exposure study and we're not looking at any relationships with health outcomes if that's precisely what it is, because you definitely want to be clear about that. And then in terms of how we report when there's no benchmark, we try and do comparisons. I mean, people are definitely interested in knowing, like, how do I compare with everybody else in the study? So we provide them that. And then we provide them with comparisons to NHANES data, both the median and the 95th percentile, or other relevant, biomonitoring data. So for example, for other things, we've used results from California biomonitoring to contextualize some of our firefighter results, for example, which was immensely useful. So that's how we try and provide context for the individual level results, particularly when there's any kind of regulatory or health benchmark to which we can compare. And then your other question about the biomarkers of effect, I'm not sure which ones you guys are looking at.
Well, we had some for oxidative stress and then inflammation.
Yeah. So we have not reported biomarkers of effect individually. We have, or, other outcomes. What we've often done is, we provide both also a summary of the aggregate results of studies. For example, in the iPhone interface that I showed you with chemicals in our bodies pregnancy cohort, we provided some high-level summaries of the health effects that we have seen so far in the cohorts based on the analyses that we've done. So we indicated that people with higher levels of PVDEs were more likely to have slightly lower birth weight babies. So we weren't providing them with, individual level results. We've measured biomarkers in our cohort, measures of inflammation, oxidative stress, and also telomeres, but we have not reported those individual level results. In part because there is no contextual, there's very little contextual information to provide. You can probably provide some information based on the distribution in the study participants themselves. We are currently, Julie and our team have a proposal pending now with NIH to expand report back to biomarkers of effect and to develop a process for doing that in the pregnancy cohort. So I don't know if we're going to get funded. We're sort of in that gray area, but this is the next frontier, and this is definitely something that we want to undertake further.
Yeah,
Well,
so
I hope you get that funding.
I do too. I do too.
So, but we actually, there are a couple of issues. So sometimes when you do some measures, you also want to get biological measures that are linked to things like the organochlorines. You get lipid data, for example. And so in all of our studies, even though we aren't doing clinical measurements, we do report dangerous clinical markers that do have potential relationships to some of these exposures, although we don't know if that's where the problem is coming from. So if somebody has a dangerously high blood pressure or a dangerously high cholesterol level, we do write to them. And we say, we even provided, I think we put it out on Derby too, because we measured their lipids, but and what we say is, this isn't a clinical assessment, but it does suggest that you need to tell your doctor that you participated in this study and that we found this, and you should go in and follow it up. And so this is the same thing that we would do in any kind of, follow-up study where we do any kind of clinical measurements. But like Rachel says, some of these chemicals have been linked to some of those outcomes, not all. But what people want to know is, well, is that why my blood pressure is high? Or is that why I got cancer? And we get those questions, but we try to answer them and say, the way we are doing work, at least now, doesn't mean permanently in the future. I can't answer you about why you got these health problems, but I can tell you this is what we measured and this is what you need to follow up. People really want to know, and I think that's coming. We're doing a whole bunch of work with exposomics and metabolomics, where we are seeing potentially the opportunity to look at individual data that shows a pattern of maybe why somebody eventually became sick, because all of our studies are longitudinal. And so what you don't always see is a terrific group separation, between everyone exposed to X versus everyone not exposed. But sometimes you'll find people who are exposed to one or two chemicals or compounds or even pharmaceuticals, because you can't exclude those, by the way, as environmentally interesting exposures, but they're not the normal definition of environmental. That we see in some cases some really strong relationships between having been given a drug in pregnancy and a kid getting breast cancer later or colon cancer later. And even though not that many people receive that drug, maybe there are no other risk factors that we can identify. So we are starting to get closer to say, well, it could be that your mom was sensitive to this, and at a critical point in fetal development, this might have happened. We're not able to do that yet. Maybe there may be a day when we can, but the question of what purpose that would serve and what the impact would be, and how you deal with also the cross-generational blaming problem. There's bad enough to blame yourself for your own illness, let alone trying to figure out how going back, what happened in your family, or to your family via someone else. There's experience with this, via the DES story. And it's a very important story because the people who were affected by something that happened to their mothers, and their mothers had to work out how they would address, quote unquote, blame for risk. But people still wanted to know, especially the people who got these very rare forms of cancer that otherwise no one ever got. So opening up this to the full, 100 yards, it's not even just what's in your blood now, but what happened when you were a kid, maybe what happened when you were your grandparents, and what can you do about that? And so we have to continue to find ways to address those questions in ways that are acceptable. That's very difficult. We're working on it because we have a responsibility to do more than just report what happened. So.
Thanks, Barbara. And thanks to Rachel too, and to all of our attendees. We are past time by a few minutes, but the break is happening now until 1:45, right, Katie? And then everybody will return back to the main room for the closing session. Is there anything you'd like to add, Katie?
Well, I just want to thank you all for joining this session. I think one of the things I learned is that the session needs to be longer.
I know, it went by really fast.
It went by so fast and it was so fascinating, and I really appreciate all of the discussion and I would love to have heard more, so. That's
And I'm sure our panelists, if you want to reach out to them with any other questions after the session, we'd be happy to answer anything.
I'd like to add, to just reinforce something that Rachel said. When all these tools get developed for a research project, they're expensive and they require an enormous amount of effort. And the question of dissemination and, make them more widely available, both to researchers, the community in general, is really important. I know that CBCRP is probably the only research organization would care about. Sorry, I'm jaded, but it's possible. But I think that Rachel is completely right that her last slide is, you should, study very carefully, because I hate putting all that stuff aside and say, oh, well, now we're done. We're not done. It's just the beginning. So, anyway, that's it.
And on that note, thank you, Veronica, Rachel, and Barbara for your presentations today, your work today. And I look forward to seeing the rest of you, all of you, at the closing. I know it's been a long couple hours. Well, actually, it's been short for me. It's gone by fast.
Thanks, everybody.
Thank you.
Bye-bye.